Hello, everyone, and welcome to week 7. We're going to be talking about alcohol this week, so I hope all of you are very warm. You didn't get hit by to be quite frankly, disappointing snowpocalypse that came and then kind of didn't. I know when we recorded last week, it was like on its way, and it was 8 inches of snow. And then I think we only got maybe an inch, and it's kind of stuck around. But I think it's all going to be melting this week. Hopefully those better days are ahead. But hope you're doing well. I hope last week's lecture about psychotropics did not get too heavy or get too deep. And once again, responses to this week's discussion board were A plus and fantastic. So thank you all for the time and the energy and the effort that you're putting on those. It's amazing to see the work that you guys are doing. So well done. Very proud of what you guys are doing so far. But this week, I know last week I said we're going to have a shorter lecture. This week, I really think we are going to have a shorter lecture. I do apologize for the length of these sometimes, but again, there's so much content that I want to make sure I'm getting to you. The big thing as we move forward, I'll make mention of this, is now we're kind of shifting gears. We've talked about the first 6 weeks, kind of setting everything up and talking about kind of the basis for substance use disorders and risk factors and the different sort of foundations of how we got here. And now in the coming weeks, this week and weeks in the future, we're going to be speaking about individual substances. Now, the book does a pretty good job about talking about the history, and I'm not so much concerned about that. We're going to be really looking into diagnosing and treating and what you're going to be looking for as you start to go out into the field. Okay, so this week moving forward, it will be a little bit different, and I'll talk about that in a second. First things first, though, this week's lecture is brought to you by the letter H. There's a lot of H's out there, but sometimes we can have trouble finding them. And if you're having trouble finding the letter H, you can find it in the middle of nowhere. It's the letter H. Here's your big idea. Alcohol use disorder is difficult to treat because of and despite the cultural and social acceptance of its usage. So again, alcohol use disorder is difficult to treat because of and despite the cultural and social acceptance of its usage. One of the things that your discussion board is going to be on this week, and then something else that I just want you to kind of think about. Alcohol is one of, along with tobacco, cigarettes, it's more of a cultural institution. I mean, it's part of our societal norms. And so for that reason, it is difficult to treat because it's a cultural norm. And at the same time, that is also why it makes it difficult to treat, is because of those social norms. It's hard for people who may be struggling with with alcohol use disorder to admit that they have a problem. It's difficult for us as friends and family and coworkers when we recognize the symptoms to know exactly how to go about it. Is this problematic? And number 3, that's also what makes it difficult, is because it is so much in our face. When somebody makes the decision to seek treatment, that's a great thing. And that's a wonderful thing. And we support that and we wholeheartedly push them in that direction. But unlike heroin, unlike cocaine, unlike, methamphetamines, alcohol is kind of everywhere we look. And I'm going to ask you to do this for your discussion board this week, but even after the discussion board, take notice about how many times you see something related to alcohol, whether it's an advertisement, whether it's a promotion, whether it's, you drive by a liquor store on the way home, you have a liquor store near your home. I mean, if you live in Ohio, when you go to the grocery store, or if you go to an Ohio Kroger, all the liquor is in the grocery store. It's not in a separate building like it is in Kentucky. So think well, even Kentucky, I mean, you got the beer aisle. So if beer is your thing, as somebody struggling with alcohol use disorder, it's everywhere. So just be aware of put yourself in the shoes of someone struggling with alcohol use disorder and think, okay, if I'm really trying to overcome this, what are all of the things that are going to play a factor in my decision to continue with treatment or to just say, you know what, a drink would really be good right now. So just think about that as we kind of move through and as you kind of go out through this week as we conceptualize alcohol. Okay. A few notes, as I mentioned before, a few notes about this in future lectures. For the sake of brevity, I'm not going to plan on diving into the etiology of the substances. The book does a good job of that, so read in the book. There will be test or quiz questions on some of the components, and it is important for us to know. What we're going to do is we're going to shift to challenges and the diagnosis and treatment as opposed to a deep dive into history. And the only exception to that may be opiate use, because I do think it's important to understand context and kind of how we got here. So that may be a little different, but for the most part, we're just going to be looking at the substance itself and the challenges, and I may tell you some stories about my clinical practice and things that I've seen for that. So, all right, alcohol. It is part of our culture. It is part of what we experience as our humanness. I mean, it is an ever present facet of our culture, right? It's almost a rite of passage in many ways. I know some of you have mentioned, that it started as young as, when you were in the single, excuse me, when you were in the single digits of age, your first exposure to alcohol. Others, normally our exposure to alcohol is in the mid, sometimes early teens, but certainly the mid-teens, late teens. We get our first exposure to alcohol. Certainly we see it as a visual representation on advertisements and stuff. I've got Brad Keselowski's car, but before that was Rusty Wallace, and he drove the Miller Genuine Draft black and yellow car. I remember that watching NASCAR with my dad growing up, seeing that. Even Dale Jr. drove the 8 car, the Budweiser car. So you have exposure to these things, from a very young age. And it is, as I wrote here, ubiquitous in all facets of life. The alcohol industry spends a considerable amount of money for the promotion of alcohol, to the tune of $486 million per year spent on alcohol advertising in the United States, with over 80% of that being spent on broadcast on television. So advertisements for television. Okay. And Kentucky specifically, I mean, that's one of the things that we are known for culturally, is how great our bourbon is. Kentucky bourbon is known not just locally, not just domestically, but all over the world as being the best bourbon that you can find. And Bardstown, Kentucky is the home of the majority of bourbon in the state of Kentucky. In fact, part of a tourist destination for many people is to take the Kentucky Bourbon Trail. My mom lived in Bardstown for about 3 or 4 years. And when you go down there, there are rick houses, there are warehouses, there are distilleries. I mean, you could throw a rock and hit a distillery. I don't advocate for rock throwing, by the way. So don't just be throwing rocks. That's probably not a good idea. But they're kind of everywhere down there, or at least within a short distance, from that area. But that's what Kentucky is culturally known for. Not only that, but $8.6 billion annually from distilling in various distilleries across the state of Kentucky. So Kentucky bourbon it's not just part of it's a cultural thing, right? When we talk about the biggest sporting event in the state of Kentucky every single year, the first Saturday in May, the Kentucky Derby, right? What is it known for? It's known for mint juleps. Well, what's in a mint julep? Bourbon, right? Specifically Woodford Reserve. Like there's that connection there. One of the biggest sporting events, not only in Kentucky, but in the world, and bourbon is connected to that, right? There are, here even in northern Kentucky, we have New Riff Distillery, Boone County Distilling. I think there is several microbreweries around here. that's what they specialize in is alcohol. I know Braxton has a place in Fort Thomas, um, and there's all kinds of others. So alcohol is cultural. Alcohol is sort of part of the fabric that is interwoven into Kentucky and into America to a certain degree. Despite of that, we do still have 15 counties of the 120 that are still dry. I grew up in a dry county in Laurel County that went dry up until I think it was 2014 or 15. It passed by 7 votes, which is crazy, to go and have alcohol sales, and it was very strange to go back to the dry county and see liquor sales going on in London. So we still have 15 of the 120 that are still dry, meaning no alcohol sales are permitted. The majority of the counties in Kentucky are wet, meaning full alcohol sales available, but there's still some that are labeled as being moist, which is that they allow them in restaurants but not package sales in the community. So that's alcohol. And the other thing is that we see we see alcohol being this fun thing. We see it being a social thing. We see it being 5 o'clock. We get off work. We go to the bar. We have parties. We've got there's at least one drinking holiday per month. The next one coming up, we had Valentine's Day, which is not really known as one, but hey, you can. And then the next one obviously is going to be St. Patrick's Day. And then we've got Cinco de Mayo, and then we've got Memorial Day, and then it just kind of keeps going. All of these are stereotypical drinking holidays, right? And we see all the parties, we see all the great thing, there is some graphic stuff coming up. So if you're a little bit squeamish, this is my warning to maybe skip ahead a little bit. But it is the reality of what happens, and that's the stuff that we don't see. Okay, those are the things that we don't see. What you see here, I've got 4 things here. Number 1 is just the classic depiction of the despair that can come with alcohol use disorder. Right here, is this is a cirrhotic liver. This is stage 4 cirrhosis, meaning that's basically a useless liver. It's got a lot of stuff. The picture that you see below, that is somebody that is jaundiced, because they had, based on their medical record, 5 drinks of wine per night for a number of years, and she is to the point now that you can see the yellowing of her skin. You can see how bloated that she is. One of the things is that it's hard for them to treat her effectively, because even a little nick, a little cut on her skin, so like if she were to just nick, blood would just kind of ooze out. It'd be the consistency of water, because that's the consistency of her blood, because of the amount of alcohol that she has consumed and how her body has bloated. When she wakes up, she will have kind of no idea where she's at. She's confused. So that's sort of the despair part of alcohol. And then obviously there on the bottom, you see DUI that happened on Burlington Pike. So those are the things that we don't see, and that they're not going to promote, and that they're not going to show. And yet, according to the Center for Disease Control, alcohol accounted for 95,000 deaths each year between 2011 and 2015. 4 out of 5 deaths were ranged 35 and older. Alcohol-related illnesses were double for those in the 65 plus range. And that's something that you're going to really want to keep in mind. Older white males are at a higher risk for alcohol use disorder. There's a higher incidence of that as they start to get older. And then approximately, and this is directly from the CDC, 1/2 of alcohol-attributed deaths were caused by chronic conditions, but acute alcohol-attributed deaths, all which were caused by binge drinking, accounted for the majority of years per life lost from excessive drinking. I apologize for not putting the explanation. So the years per life lost. So on average of these who passed away, they lost on average 29 years off of their life, on average, versus the expectation of how long they should be living. Okay. Also, things that you're not going to see, according to the National Institute of Health, NIH, alcohol-related emergency department visits increased 47% between 2006 and 2014. That's an annual increase of about 210,000. And then in 2015, alcohol-impaired driving fatalities accounted for over 10,000 deaths, which is about 1/3 of all of the overall fatalities with driving. So we see that it's an issue. We see that it's a problem when we start to look into the numbers and we start to kind of pull the curtain back a little bit. And this is just for America, by the way. I'm sure worldwide it's obviously much greater. So we start to think like, okay, well, what do we do? Well, first of all, how are we going to diagnose? How do we make the differentiation? So if you remember, when we talked about diagnosis a few weeks ago, I gave you the two examples of the kind of the stereotypical sorority girl and then the guy that comes home every night and has a few drinks. In the DSM-4, we had a differentiation between alcohol dependence and alcohol misuse. Well, in the DSM-5, and that's what you will be using if you're diagnosing or if you're working with anybody that does diagnosing, we do not differentiate. There is no differentiation between misuse or abuse and dependence. It's all alcohol use disorder. It's all lumped into one thing, okay? What we're looking at, again, these are the 11 criteria, and we're looking to see how many symptoms. Now, overall, what you're looking at is how much of an impact does their alcohol use have on their functioning. It's not necessarily that they're, somebody can get really drunk several nights a week, but it doesn't really have an impact on their functioning. They don't have impairments. They're not getting behind the wheel of a car. Their life isn't otherwise mismanaged in any way. They may just drink 5 or 6 beers a night, and that's just kind of where they're at. So for several years, and I know this says opiates, but it's all the same. It's for alcohol use as well. Until they start to have something that gets in the way of their life, we don't necessarily consider it problematic. And that can sometimes be a little bit hard to understand. Okay, somebody's coming home and they're drinking 5 nights a week, let's say, but there are no problems, right? How can we not? They're drinking every. Well, there's not impairment. They are, in this case, drinking responsibly, if you want to put it that way. Until they start to experience some kind of distress or clinically significant impairment, we don't really diagnose them with an alcohol use disorder, right? So what you would start to see is maybe number one, if they stay at that 5 drink limit, okay, but let's say they go from 5 to 6 and up to 7. Now their drinking's increasing. Well, there's number one, right? They're not really maybe trying to control it, but they are spending activities in order to, they're taking time out of their day to go get alcohol, or they've got to make sure they got it stocked, or there's a lot of anxiety. Well, there's 2, right? So you just keep going down that path until, you have enough criteria. But if somebody's drinking several nights a week, or they've got a binge drinking issue or whatever, and there's not really any kind of significant impairment or distress, then we kind of don't diagnose it as an alcohol use disorder. So that's just something to kind of keep rattling in your brain. A few differences in for gender consideration. Overall, men are more likely to consume alcohol to excess than females. Males are more likely to binge drink. So if you do treat a male or are working with someone who has alcohol use disorder that is male, they're more likely to drink in excessive quantities. They're more likely to report heavy drinking or drinking to excess. And again, as I mentioned before, older white males are at a particular danger for alcohol-related disorders. Okay. Cultural differences, things to keep in mind in respect to culture. Caucasians or white people are more likely to drink overall. However, indigenous Americans and Alaskan natives, they report the higher rate of binge drinking. So they will drink, they will consume an excessive amount of alcohol in a short period of time. Whereas Caucasians will drink sort of like greater overall. When we look at binge drinking or sort of acute alcohol disorder, you're really focusing on Indigenous Americans and Alaskan Natives. Again, that's more of a cultural impact than anything. Those with a higher socioeconomic status report a greater frequency of drinking, meaning they'll drink more often, whereas people with lower socioeconomic status will have a greater quantity of drinking. So they may not drink as frequently, but they may drink more over time through binge drinking. Okay, so a few cultural differences to keep in mind. Very quickly, we're going to touch on absorption and blood alcohol concentration. With an empty stomach, the absorption rate of alcohol depends on the concentration or proof of alcohol. The higher the proof, and they talked about how they do proofing. And so proofing, you basically take the percentage of alcohol by volume, double it, and that gets your proof. So if something is 50% alcohol by volume, we would say that that's 100 proof. I don't see if it's on here. Yeah. So I don't know if this will come through, but I got this from, I did the Kentucky Bourbon Trail, and it's not really great, but you can see right here, it says 45% alcohol by volume. Again, that's not going to come through. Anyway, and then over here it says 90 proof. So again, 45% alcohol by volume equals 90 proof, so on and so forth. So if you have something that's 90% alcohol by volume, which is typical moonshines, then you're going to have, it'll be considered 180 proof, right? So that you'll take the percentage of alcohol by volume, or ABV, double it, and that gets your proof. So the higher the proof, the higher absorption. The more alcohol by volume, the quicker it's going to get absorbed into the bloodstream, and the quicker people are going to start to feel, drunk. Food and water will help to slow this process down. Proteins in food will retain alcohol, so that will help with absorption. Certainly the carbohydrates and the sugars will help with that as well. Water will dilute the concentration, so lower concentration, lower absorption. And carbonated liquids actually speeds up absorption. So the new hotness now are Trulies and White Claws, which are disgusting and should be banned by most states, if not all. But they are carbonated beverages. Same thing with champagne. They're going to hit the bloodstream faster. There's going to be greater absorption. And because of their taste, and because you can't really taste the alcohol, because what it tastes like is trash, but you can't really taste the alcohol, it's a lot easier to consume more. It's going to hit the bloodstream faster. You get drunk quicker, so on and so forth. Okay, keep that in mind. Here's a curve to look at how it works. So when we look at blood alcohol levels here, normal sober, right? We go up to, when we get to about 0.05, 0.06, we have sort of that euphoria. That's what people are looking for when they go and they have a couple of drinks, or they have a few, have a few beers at the local pub. They're looking for that sort of happy, euphoric feeling. And then once you start to cross that, then we kind of start to see the negative impacts of alcohol. We're looking at the depressant part of it, the dysphoria, the sort of, woe is me, kind of slurring around, and loss of motor functioning and that kind of stuff. Okay. And then this one over here on the right is how the alcohol concentration in your blood, right? If you consume 6 ounces in the span of an hour, you can see how quickly that can go up, right? So it's important when we talk about binge drinking, you can see just how quickly blood alcohol content can go up without that moderation, right? So if somebody is, caught up in the moment and they're just pounding drinks and they do a ton in the span of an hour, you can see how quickly that can go up and how it can become very dangerous very quickly, right? So blood alcohol concentration is something to keep in mind. So why is this difficult to treat? Number one, stigma. Not just with alcohol use disorder, but treatment in general. It's hard for people to really acknowledge that there is a problem and then go get help for it. Especially because we can make jokes, oh, you know, I'm an alcoholic or whatever. We throw that out there so often sometimes, and it can lose its meaning to a certain degree. But alcoholism is a serious issue. Alcoholism is very difficult to treat because of the stigma associated with it. Social and cultural pressures. There is so much pressure involved with drinking, whether it's, you know, a group of buddies going to the local golf course to, you know, get a group together and have a round of beers, you know, or to you know, the bachelorette party where, you know, you just pounded White Claws and champagne and mimosas and wine, right? You know, there's the you know, the girls get together where we're just going to have a bunch of wine Wednesday, you know, Thirsty Thursday, sometimes Thirsty Tuesday, depending on how, but Thirsty Thursday. And then obviously the weekends, you know, especially for you guys as college students, culture, you know, college pressures, fraternities, sororities, you know, nightlife, partying, going to the bars, going to, you know, it's part of the cultural stigma and the cultural pressure that goes on there. Lack of awareness or insight, especially when it comes to family members. We don't always know what indicates, or we're not always aware of what may indicate an alcohol use disorder, or things to really look for somebody struggling with alcohol use disorder. Further, sort of the bravery to go say, hey, I think that you may have a problem here. I think that there's something going on here. Overall, women are also less likely to seek treatment than men out of sometimes fear, shame, or number 6, denial. Just simply, you know, I don't have a problem. There's nothing wrong with this. I can stop when I want. I've got control over it. When in reality, it's got control over the person. So that's why it's oftentimes difficult to treat. Also, going back to that stigma, one of the things that I find interesting is that when I have somebody coming into my office, they really love to talk about the hierarchy of substance use, right? Well, yes, my life is falling apart, and yes, I'm really losing my family, and yes, I'm drinking, yes, I've been to the emergency room, yes, I've had seizures, but I'm not like those heroin addicts. I'm not doing that. I'm not like those meth users. I'm just drinking alcohol, right? As if it makes a difference. So there is that component as well. The thing about alcohol is it may not kill you like that, like opiates might, but it's more of like death by 1,000 cuts if you're not taking care of it. Okay? So a few dangers, medical concerns to watch out for. First of all is delirium tremens or DTs, which is, you know, when somebody's got, you know, the DTs, they will have really hard time with motor functioning. So if they're signing their name, their hands will shake, and they'll oftentimes be unable to put their fingers together because they're shaking so bad, and it's hard for them to walk sometimes in a straight line because they can be a little wobbly just because of how, you know, they're trembling because of the neurological issues that come along with long-term chronic alcohol use. We talked about cirrhosis of the liver, which I showed you that before. Wernicke's-Korsakoff syndrome. And I put a picture up here of the Wernicke's area. So you've got a part of your brain that's responsible for the understanding and comprehension of language, and it's called the Wernicke's area. It's also got a connection to what's called the Broca's area, which are the sort of the muscle movements involved for learning how to speak or for getting words out. So the Wernicke's area is where our speech, what we believe, now there's more data and evidence. That's the thing about science. We can have the thing that we know and then it can change. So it's kind of backtracking on this, but what we understood or what we understand it to be right now is that is where the area of our brain where language is really developed and where we can comprehend it. It's for speech recognition and comprehension. And so when this part of our brain gets damaged, if you notice where it is, it's right in the midbrain. So when you have that area get damaged, it's right there next to the hypothalamus and the thalamus. The hypothalamus, as we know, is our body temperature, our energy, memory, and stress regulation. And then our thalamus is for sensory and motor signals. It's kind of like the centralized hub where a lot of things get communicated to and from. And so when you have that part of your brain damaged, right, somebody that's struggling with this or this syndrome or encephalopathy, wet brain encephalopathy, which is the title of where the wet brain documentary comes from, they will speak just gibberish, and they'll think that they are talking perfect English, but it comes out as just and they think that they're speaking, language. But really, it's just gibberish, and none of it makes sense. So that's something that is for long-term chronic use. Obviously, kidney failure, high blood pressure, stroke, digestive issues called alcoholic gastritis, and then also a global increase of risk of cancers, oral, esophageal, liver, and kidney. So a ton of dangers of medical concerns. There was this idea at one point that that there was a healthy amount of drinking that you could do and it would be okay, but the data is actually showing that there is not. That any alcohol that you consume carries with it some version of a risk. Okay, so there's no healthy amount that would be okay. So how do we treat it? Progression of treatment. Long-term chronic use. If somebody has been drinking for a long time, it is very, very, very dangerous for them to just stop drinking. Not only for the delirium tremens, but also they have a higher risk of seizure. Very, very, very high risk of seizure. So it is important that if you're treating somebody or somebody comes to you and says, hey, I got alcohol use disorder problem, you can tell them to go see the doctor, PCP, whatever. But what we recommend, what I recommend as a clinical professional, they need to go to detox. They need to go and be around a team of medical professionals for 5-6 days, 7 days if they can. 2 weeks would be great. That would be perfect. But not all of them will do it for 2 weeks. But if they don't want to commit to 30, 60, 90 days, at least get them in front of a medical professional in a medical facility for at least 5 or 6 days to ensure that if they do have a seizure, that there is medical help there. From there, again, if they're willing to go to long-term treatment, cool. 30, 60, 90 days. Sometimes people need 180 days. It's really, what are you willing to commit to? Outpatient treatment, we can do therapeutic interventions, do a lot of cognitive behavioral therapy with alcohol use disorder. Sort of my bias is dialectical behavioral therapy, which we'll talk about later on. And then motivational interviewing, kind of talking about, where does this desire to drink stem from? How can we, what changes could you make to help make a difference for you? We also have medication-assisted treatment that can be used. We have 3 that we do at Journey Recovery Center, and it's kind of the 3 that's the most well-known. It's the 3 that they mention in your book. You got intramuscular or oral naltrexone. The intramuscular version is known as Vivitrol. And Vivitrol is a 28-day injection that can help to reduce the desire, triggers, cravings for alcohol. And it's in your system whether you want it or not. Oral naltrexone does the same thing, except you have to take it every day. It's a pill form. It's called Revia, Revia, and you take it. It's in a pill form, but you got to take it every day. So if I prefer the intramuscular version, but the downside of that is it's really expensive. It's like $700 or $800 a shot, and that's with a discount. So that can get pretty pricey if you have private insurance. If somebody's on Medicaid, it's completely covered. Antabuse, I'll skip that. I'll come back to that. Acamprosate is similar to oral naltrexone. It can really work on more of the neurological functioning as it relates to triggers and cravings, can help to lower those. Antabuse is another pill that you take. Again, these pills you got to take every day. That if you even smell ethyl alcohol, you will get nauseous. And then if you ingest it, you will violently throw up. Like it's to do more negative reinforcement or negative punishment of alcohol use. And then also support groups. So whether it's Alcoholics Anonymous, Smart Recovery, some kind of support group is huge for that population. Other treatment considerations. What's your goal? Okay, so what is your goal as you're treating them. And that goal centers from the patient. I've got some patients that come and see me and they want to quit altogether. That's their goal. I've got some that have been drinking every day or drink during high stress periods and they want to learn how to moderate that. It does not have to be binary. So this isn't a black or white or 0 or 1. The goal does not always have to be, I'm quitting drinking altogether. I'm going to stop it completely, because that may not be a realistic goal for some of the people that you're working with. Moderation is and can be a treatment goal. Now that kind of sounds bleh, but going from daily drinking, if somebody's drinking every single day and now they're just drinking once a week, that's a goal and that's progress, right? They're not drinking every day like they were. They may not be drinking to excess like they were. Now they're just drinking once a week. It's more moderated and controlled, and that can be a little more tolerable. Sometimes when, you tell them, you work with somebody, it's like, oh, you can't drink ever again. It's a lot of pressure. And sometimes that pressure can lead to them drinking. Also be careful with countertransference. Now, I don't know if you guys have had much education on this, but we have two things as treatment professionals that we have to think about. Number one is transference, which is the patient that we're working with deals with their stuff with us. So one of the things that I have to be very careful with my younger female patients is that they don't see me as a father figure. And that's just an example of like, well, now they're coming to me for all their problems and they see me as kind of a fatherly figure because they have issues with their father. So I have to be very careful and kind of guard against that and be aware of that, right? Well, we can also have countertransference, which is we're working on our stuff through a patient. So maybe if I have this like dark thing with alcohol that's harmed me in my past, and I'm working with somebody that's got alcohol use disorder and they just want to quit, they just want to moderate their drinking. But I wish that my person that I've got an issue with, I wish that they would have quit. If they'd have quit drinking altogether. Well, why don't you just quit drinking altogether? Like, why do you have to moderate it? Well, and you got to be careful with that. So that's countertransference, is that we're doing our stuff kind of with them. Keep in mind, baby steps are steps. Okay, so somebody working with alcohol use disorder, maybe if they cut back on drinking one day, and the goal is to cut drinking 6 days, they cut down one. That's a baby step. That's huge. Maybe if they take a different route home, that's huge. That's a big step, but it can sometimes come up as a baby step, right? You can see like a very small thing, but that's the space that you have to work in. And be patient with the process. Naturally, we want the sense of urgency and all that stuff, but we have to be very patient and allow our patients to kind of work through. One of my alcohol use disorder patients, it took about a year before they finally kind of got on board, and then in the next year, now we're 2 years in, and they're just really, it's amazing the amount of progression that they're making. So it can take time, but that's where we as treatment professionals, we allow them to kind of work through that process. Okay. On to week 8, familiar drugs. It's a lot of reading. Just scan it. Okay. It's a lot of reading, and I don't know how much about like the St. John's wort and all of those things that we're going to really talk about. We'll certainly talk about caffeine. We'll talk about tobacco, but the over-the-counter stuff may not be as much of a priority for that. So make sure you do your discussion board this week. A fun little project I think will be good. Send me feedback, and I put a little riddle here. Can you write down 8 8s so that they add up to 1,000? Kind of test your brain a little bit. Got any questions? Send them to me. Thank you for watching this week. Let me know if you got questions or concerns. Keep up all your good work, and I will see you next week. Okay, bye. Oh, Canadian geese are proof that evil exists. Live mahalo. See you next week.